Hello, we're back talking about drugs and molecules rather than about personalities in the context of bipolar disorder. In terms of therapeutic approaches to bipolar disorder, a very important statement is that many bipolar patients avoid therapy or remain only partially compliant because they don't wish to give up the pleasant feelings during the manic phase. Among the most important points to be made is that non-compliant patients may risk suicide. DSM-4 cautions that the presence in a depressed patient of a positive family history of bipolar disorder or acute psychosis probably increases the chances that the patient's own depressive disorder is a manifestation of bipolar rather than unipolar disorder, and that antidepressant therapy may incite a switch into mania. In other words, psychiatrists have a lot of concern that if a patient is a bipolar patient rather than a unipolar depressive patient, giving that patient an antidepressant may precipitate mania. And so this is a constant concern for bipolar therapy. Added to that concern is the fact that DSM-5 may reclassify some major depressive disorders as actually being on the bipolar spectrum instead. And this would then have major ramifications for how one takes drugs to suppress bipolar disorder. We'll all have to stay tuned about this possibility. In addition to drug approaches to bipolar disorder, we should talk about surgical and electrical intervention. Lobotomy or psychosurgery was used in the 1950s and 60s and removed large portions of the brain. These types of surgeries are no longer performed. Electroconvulsive shock therapy should be distinguished from deep brain stimulation, which is much more delicate, takes place within the brain, and at much lower voltages. ECT, electroconvulsive shock therapy, is now administered under anesthesia, for instance, muscle relaxants, so that there are no muscle convulsions. There are various placements of the electrodes, pulse widths, pulse durations, and frequencies. And excellent psychiatrists believe that there are situations in which ECT, electroconvulsive therapy, is indeed a highly effective treatment for severe depressive episodes. Now, how does ECT work? It is transient, and over 100 theories have been offered to account for the efficacy of ECT. These range from the molecular to the systems, and none of them have been proven, but they all remain viable hypotheses. The drug therapy approaches to bipolar disorder, of course, began with lithium. The lithium ion is a very simple one. On the periodic table, it's just above sodium, and the four blue-colored ions here are the ones that we usually think about in drugs in the brain: sodium, potassium, magnesium, calcium. We don't really understand how lithium works. Its therapeutic effects begin in less than 5 days and require several weeks. Lithium is quite poisonous at higher doses, eliciting convulsions, and so patients need to be monitored carefully. Indeed, drugs that were originally discovered as anticonvulsants are also used for bipolar disorder. They also require several weeks for full effects. We don't understand how these drugs work either. The general statement that people with manic symptoms may be more active neurally than people without manic symptoms has been invoked as a way of explaining that anticonvulsants might be quieting down excess neuronal activity. But in fact, we have no reason to believe that valproic acid or lamotrigine, both approved for bipolar therapy, are acting on ion channels, or even that they're acting outside the cell. So there are lots of mysteries about drugs originally discovered as anticonvulsants used for bipolar therapy, but they do work. Lithium was discovered in the 50s and 60s as a bipolar drug, and here are 5 example patients in the very early days of experimentation using lithium. Here's a patient who had mostly manic episodes when he started lithium. He was rather well controlled. This patient also had manic and 1 depressive episodes. Lithium helped. This patient mostly depressed. This one true bipolar, also helped with lithium, and this patient as well. So there's no doubt that lithium works, but how does it work? How is it acting? We really don't know, but there are some good guesses. All ideas about lithium assume an intracellular target, and that is simply because no high-affinity extracellular receptor has been identified for lithium, as also true for valproate. So this is not to say that lithium and valproate are acting in an inside-out fashion in the endoplasmic reticulum and as molecular chaperones, but it is impressive that we simply assume they work intracellularly. Lithium does enter cells through several channels and ion-coupled transporters that normally serve for sodium, which, as you'll remember, is just below lithium on the periodic table as a monovalent cation. The therapeutic concentrations of lithium intracellular are probably several millimolars. Most of the ideas about lithium involve its ability to inhibit enzymes, and most of the suspected enzymes manipulate high-energy phosphate bonds. They are kinases or phosphatases, but which ones are not clear. We'll have to stay tuned for this very interesting story. Antipsychotics are also used in bipolar disease. We will discuss antipsychotics in greater length when we talk about schizophrenia in the next few lectures. In 2006, the FDA approved quetiapine, an antipsychotic, for managing mania and hypomanic episodes in bipolar disease, and risperidone is also used off-label. One should also point out that psychotherapy is a useful adjunct to medication. Cognitive behavioral therapy, which we mentioned in connection with major depression. Family-focused therapy, so that family members understand how to deal with a bipolar patient. Interpersonal social rhythm therapy, and psychoeducation that teaches people with bipolar disorder about the illness and its treatment. So that brings our discussion of bipolar disorder to an end. I hope it's given some useful knowledge, but we have a lot more that we need to learn about bipolar disorder.